Hi, I'm Kelly Linvoy from Arthritis Consumer Experts. On September 21st, 2020, Southlake Regional Health Centre notified the leaders at the Arthritis Program, one of Canada's leading community arthritis programs, that it was closing TAP effective January 15th, 2021. ACE is part of a coalition of Canada's leading arthritis patient organizations, including the Arthritis Society, Canadian Spondylitis Association, Lupus Canada, Sjogren's Society of Canada, and the Canadian Arthritis Patient Alliance, who were all shocked by this news and are unified in opposition to the TAP closure. Joining us to speak about this issue are Dr. Carter Thorne, Chief of the Division of Rheumatology and Director of the Arthritis Program, and Carrie Barnes, an arthritis patient who lives in Central Ontario, person living with rheumatoid arthritis, and is a patient ambassador for TAP and has been involved in the CATCH research for over 10 years. Dr. Thorne and Carrie, thanks for joining us today.
Thank you, Kelly. We really appreciate the opportunity to share this information and the take on it.
Hey, Kelly. Thanks
Carrie.
for letting us be here today and share our story and talk a little bit about what's going on.
To get us started, Dr. Thorne and Carrie, audience who might not be familiar with the Arthritis Program, which we will be referring to as TAP during this interview. What is TAP? How long has it been operating?
Well, thank you very much, Kelly. It's been my privilege and a great pleasure to work with a group of individuals committed to looking after people with arthritis and to people who have arthritis like Carrie. Even though we were originally funded as an inflammatory program, we actually do provide what we like to call a portal of care. So we provide services for people who have osteoarthritis, chronic pain syndrome and fibromyalgia, osteoporosis. We provide an early arthritis clinic. So it's really a portal of care. And that's where the success is. If you have a problem with your arthritis, then you can look for solutions with TAP. One of the things that we did early on was embed clinical outcomes. Now, hospitals are usually into counting, but they count for administrative purposes. Did you have enough patients? How much money did you spend? And we did that. We were quite successful. We always had very effective use of resources. And when we got our funding in 91, it allowed us to bring a full-time at a bit more OT and a full-time and a bit more physio and a full-time pharmacist and a part-time social worker, a kinesiologist, a dietitian. That was the impact of that group. We embedded research because we wanted to know how we were doing clinically. And as you indicated, for 13 years, so TAP is now 27 years old as a funded program from the Ministry of Health. And for the past 13 years, we've been participating in clinical cohorts. And one of the most important ones is CATCH, which Carrie belongs to and she'll tell you about. And we've demonstrated through that a couple of things. But one of the most important thing is we didn't really realize the impact that a program of interprofessional care would make on patients. And that impact is that we see patients sooner after symptoms begin than any one of the sites in Canada. We start treatment sooner after diagnosis than any sites in Canada, and patients do best-in-class outcomes. And the other piece of that, which is really important for the payers, we think, is that in CATCH and in general, people with rheumatoid arthritis have had a great experience with the introduction of biologic agents, which are really have been game-changing for those that require them. But in our hands, that is to say in new markets cohort, only less than 1% of patients are receiving a biologic agent or targeted therapy. And that's different than CATCH, where it's about 20%, and different in the community at whole, where it's 25% or more, 25 to 30%. Now, what does that mean to the system? Well, if we just annualize the savings or cost avoidance in new market, the avoidance in costs is about $2.5 million or more. The cost of TAP for all it does is about $500,000 or $600,000, but $600,000. So the return on investment is quite striking. It occurs because we've learned how to use the medications differently, but more importantly, because people who have arthritis and come through the program are exposed to an environment, a culture that is embracing and where we emphasize self-management.
Point, Carrie, we've just heard sort of that incredible clinical and research history of TAP. I'm really interested to hear your insights on that.
Of course. So when I was first introduced to TAP, I was in a pretty desperate state. I had significant joint swelling. I was in a lot of pain, unable to care for myself really or my family. It came on very suddenly. So I was really searching for some care and not getting it from, I was really stuck with walk-in clinics, kind of emergency room kind of things. I did end up with a referral to a rheumatologist, but the wait time was going to be 9 months. And I wasn't satisfied with that because I was struggling really to live really. And so in a roundabout way, I got connected to TAP, and then things really started to move for me. In fact, it was within a couple of days that I was able to be diagnosed and had treatment started. I think what was most significant for me was this unified approach. I met with numerous different healthcare providers, and they all had the same answers. We had discussions about what was going to happen as far as treatment was concerned. And although the treatment was a little bit daunting, I felt confident because this was unified approach. They all seemed to speak to me about it. It wasn't a decision that was made for me. I was included in that discussion. And I guess I felt that I could then follow through with what I needed to do to treat what was happening in my body. And then came the education piece. I came back to TAP for, at that time, it was actually a week long. I think it's different now, but that was like 10 years ago. So I came back for this education program. I learned about my disease. I learned about the medications I was taking, dietary suggestions, even met with a social worker to see how I was doing, how my family was managing with the diagnosis and treatment and all of that, finances, how was it going with missing work and all of that kind of thing. And I like, it was dreamy. It was just this wonderful program where I felt supported and cared for.
It now leads us to the issue and the news that Southlake delivered to you a few months ago, and it really is. It's so perplexing for our patient organization and leaders in the community that something that is life changing and life saving and is also saving money to the healthcare system, why would you be closing it at this time? And what we've heard from Southlake is that it's closing TAP because of the financial deficit it's facing, and that's been exacerbated or made worse by the COVID pandemic, and that the hospital is focusing on delivering programs and services that can only be provided in a hospital. I think we're very interested, our audience is very interested in both of your responses to that reasoning from the hospital. Carter, I'll start with you.
Yeah, I think one of the that is the ostensible reason we've heard. Again, to remind you, our budget is in the range of $500,000, $600,000. The budget of the hospital is $455 million. So we represent about 1.1% of the budget. It's not only that we're a cost center, but we're a cost saver. As I mentioned, we're a cost avoidance. And it's been remarkable, the response that we receive from across the country, as you've pointed out. Not only do we have the support of patient groups, but we also have the support of researchers. In the 25 years and more that we've been doing the arthritis program, we have documented that we have fewer visits to emergency department. That is to say, we have reduced the burden on the emergency department. Carrie already told you her experience. Now, she doesn't live in Newmarket. She comes from outside of Newmarket, but it's the same in all communities. You end up in a walk-in clinic or emerge. We've also demonstrated that we reduce bed requirements for the population that we service. So we can't prove those new ones because we're so mature in our program So we've done those things. I get the concept that the hospital doesn't feel that a program that is mainly dealing with outpatients, because we keep them out of hospital, is not appropriate. I understand that concept, and when it was approved in 1991, that was the model, to be clear. And I think it's reasonable to consider moving out, but moving out with the resources that are required to keep it going. So I believe that we have a model that is sustainable in a community with a rationale in terms of cost savings to the system that more than support the ongoing use of it.
Carrie, from a patient perspective, how are you, and I'm sure you've talked to other patients as well, how are you processing this news from Southlake?
Wow, good question. I'm not a big crier, but I did have a little cry about it. I feel like I really felt like I was losing my ability to live, literally, physically, and I was losing. I'm a super active person. It was part of my identity, and that was just slipping away. And really, truly, TAP gave me my life back. I cannot imagine where I would be today if it wasn't for all those years of planning and processing and research and sweat, blood, and tears. I'm sure that they've all put into that program, because it really was the cornerstone of my success. And I cannot I can't imagine what people are going to do now. They'll wait in emerge rooms. They'll wait 9 months or more to see somebody. They don't want to go to a hospital right now. Nobody wants to go because of the COVID pandemic. So they're going to wait until their symptoms are so severe that they just can't possibly do anything else but seek some sort of emergency medical attention. And my heart breaks for them. I wish this was not the reality we were facing.
The harsh patient reality is that there are going to be patients affected that will be on different parts of the journey. You talked
Yeah.
about you're in remission. There'll be some patients who've just recently been diagnosed and are just
Right.
starting their treatment and care program at the TAP. And the really, I think what our viewers have to understand is that in January, Carter, correct me if I'm wrong, but there will be probably upwards or more than 1,000 patients immediately and adversely affected that you're describing, Carrie, that are going to be out on the street scrambling, trying to find a way to continue their care at maybe very critical times in their
Yeah.
journey.
Yeah, as you're pointing out, Kelly, we have about 6 clinical equivalents seeing patients, and with those 6, we see 9,000 attendances a year and 2,200 unique patients. That is a large number. So it's over 1,000, as you mentioned. It's 2,200.
Okay.
And that's across the diagnoses, but rheumatoid arthritis or inflammatory joint disease, it's really inflammatory joint disease that we manage.
Okay.
So that's really important. We just actually this past week started our last education program for inflammatory joint disease. So these are the people that Carrie kind of identified a moment ago where she was 10 years ago. I've just learned, I just got, I'm still coping. I haven't got all the information and all the buy-in yet. Personally, I haven't integrated it all. I haven't owned it yet. And you're not going to be here in 6 weeks. I mean, what am I going to do? You know, and you've gone from a system where it sucks, you know, it's 9 months, but that's where everyone's waiting, to a system that values you as a patient with your problems and deals with it. And now they've gone from the generic system of this, you know, our care in general these days, especially with COVID, to having this commitment by learned people who are experts in arthritis care, and you're being introduced into our rather robust, sophisticated program to make you the best person you can be. And then we have to inform them, which we have now, is that this program will be gone in 6 weeks. So have a nice day. And the hospital did indicate that patients would still have access to the rheumatologist, but that's not part of the hospital deal. They indicated that they'd be transitioned to resources in the community. And I can tell you from that study done by the Institute for Clinical and Evaluative Sciences, that's the research part of the ministry kind of thing, is that there aren't any resources in the community that can cover the population that we're dealing with.
Where are you at in your discussions with Southlake in terms of, do they have a complete or better understanding over the last few months of discussions with you about the program, about the benefits of the program, and also the ministry of health and the minister? Because I think the center is in Minister Elliott's riding, so obviously she's familiar with what's going on. What are you asking both of those groups?
The hospital actually has not had a public announcement about the closure of the arthritis program. It's only through patient initiatives and others that there's actually been news. And right now there is no plan at the hospital level to have a public announcement. They'll be trying to identify patients that are currently active with TAP and notify them. But there's no plan to notify the community. And, Newmarket's not a large community. We serve a large area, but it's not a large community to do that, which I thought, as the sole proprietor of healthcare in Ontario, in Newmarket, I mean, there's only one healthcare facility aside from offices and walk-in clinics. I think they have a responsibility to share that transparently with the community in which they provide service, because people do see there's no alternatives. You don't have 30 hospitals like Toronto does, or Vancouver, or whatever, or other types of places. So at this time, they acknowledge that the arthritis program is a really good program. It's just that it's not one we're going to have, which is kind of striking, because they like to call themselves leaders in care and innovation. And we actually are leaders in care and innovation as well. So they have not been as supportive. They've given us they're suggesting they can do some stuff in kind. We need more than that. They have not given us support at the ministry level. That is to say, the hospital has not advocated at the ministry level. Our ability to get any notice at the ministry level with COVID, as you pointed out earlier, is very limited. But so we continue to try and find if we can salvage something out of this, because we believe passionately that our ability to provide the best care possible is being taken away from us.
What can concerned patients do? Who can they communicate to voice their support for TAP, and they're hoping that there is going to be some sort of solution?
The advocacy that politicians listen to are both letters received and social media. And as you indicated at the beginning, the hashtag #SafeTapNow is where we'd like people to share their experiences and their concerns. So hashtag #SafeTapNow, I think, has to become the vehicle that people attend to, sharing their experiences if they've had personal experience with TAP, and sharing their concern and consternation regarding gutting a program that is a model for the rest of the country, and which many people have told us, including provincial ministries and other provinces, that they would like to have as the model of care strategy.
I have taken the time to write letters to the Southlake CEO and chair of the board, Christine Elliott. I did actually write her a letter, so it's kind of surprising that she didn't know about it. I guess maybe somebody's kind of going through her mail. I don't know. But yeah, write letters. Hashtag #SafeTapNow is a great forum to voice your experiences and stories, and share it. Tell your friends and family. Use the social media that you've got, and yeah, make it known.
I want to thank both of you today for taking the time to helping us understand this very short-sighted, regrettable decision. We do hope that as you continue to talk to community partners, that there's a solution, and that there's going to be a continuity of care for over 2,000 patients who are going to be affected and quite literally thrown out on the street in January. On behalf of our organizations, Arthritis Consumer Experts, the Arthritis Society, Sjogren's Society of Canada, Lupus Canada, and the Canadian Arthritis Patient Alliance, and the Canadian Spondylitis Association, we're going to do everything that we can to promote your story, show our support, and help people understand how they can get involved and take action. So thank you both again.
Thank you, Kelly, and thank you to our patient advocacy groups.
Thanks, Kelly. Appreciate it.